I welcome you to this webinar on Carbetocin in action. Case studies from the neighborhood. Dr. Heathrow Healthcare, as you know, we have got 25 plus years of excellence and 36 state-of-art manufacturing facilities. We have got 300 plus products in portfolio with presence in 126 plus countries, 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is a 360-degree solution provider. We strive to fulfill unmet healthcare needs. We reach out to customers across India. We have got a wide product range encompassing multiple specialties like gynecology, dermatology, orthopedics, pulmonology, etc. We pioneer in quality and innovation, and we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. But today's, Carbetocin, the webinar today, the drug in focus is Carbetocin. We all know Carbetocin is used in the management of prophylactic management of PPH. PPH is a condition which is better to be read in the textbook and discussed rather to be seen in practice. We all will agree. And although there are many papers and studies about Carbetocin, we would like to have our own doctors' insights and experience about Carbetocin from their own personal experience, for which we have got Dr. Abhay Sukhatme today. Dr. Abhay Sukhatme is an MBBS MD from BJ Medical Pune. Sir is reproductive endocrinologist and director and consultant at Sukhatme Maternity Home. Visiting faculty at Arogya Seva Sangh, Ayurvedic College, Nasik. Visiting faculty at Ashoka Medicover Hospital, Magnum Hospital, Sahyadri Hospital. Dr. Sukhatme is past president Nashik OBGYN Society, has organized a conference as a secretary with Foxy, UNICEF and GOF. Scientific Committee Chairman for Gestosis Conference, Nasik. Dr. Sukhatme has conducted workshop in charge of vaginal surgeries with national and international faculties at AMOGS and UA Foxy conferences. Faculty at various state and national level OBGYN conferences, has received IMA Lifetime Achievement Award in 2023. Dr. Sukhatme has written various articles on social and medical issues in print media, newspaper and magazines, and has conducted Menopause Awareness Week with Lokmat Sakhi Manch and adolescent programs at schools and colleges. One of the few private practicing gynecologists, Dr. Sukhatme has conducted laparoscopic tubectomy camps organized by government and Jilla Parishad. Welcome, Dr. Abhay Sukhatme, and sir, over to you.
Good afternoon, sir. Probably we are meeting for the second time.
Yes.
We met initially.
Yes.
Yeah, Milotin.
Milotin.
Yeah. I think I will go on. I have not written any slides about the cases, but I will write to share my experiences with the Carbetocin.
That's exactly we want.
Probably is expected from me.
Yeah, and that is what our participating doctors also would like to share, have your own experience on that drug. I'll move on to the slides.
Yeah, surely. Now, postpartum, everybody knows. I won't go into the details of the pathology and physiology of the PPH because practically all practicing gynecologists are well known with the PPH. Each and every conferences, there is a lecture on the PPH, there is a mock drill, and each and every gynecologist, it's a nightmare. So each obstetrician is very well prepared with the PPH. As we know, PPH is causes. 4 common causes are 4 T's are there: tissue, trauma, thrombin. Yeah, we can go to the next slide also. And the most commonest factor which we are after is the tone. I think we will escape all those slides. Yeah, this is what I was saying. The thrombin, trauma, and tissue. These are the 3 common causes, and 4th one, which probably in each and obstetrician has faced in his life once or twice or multiple times is a tone. And that is a uterine atony. And that is where the role of this uterine tonics comes into the picture. That a preventive role of these uterotonics and various drugs is extremely important in preventing the PPH. Regarding with the uterotonic drugs, the thrombin, trauma, and tissue, these are not related with the uterotonic drugs. These are the causes are different, treatment is totally different. We'll go to the next slide, sir. And these are the various clinical findings in the PPH. There is a tenderness, there is a circulatory collapse, there is an increased abdominal girth, there is a tachycardia, there is all pictures of initial shock, that is a hemorrhagic shock. And most important is the gush of vaginal blood, that is a PV bleeding. And the loss, normal loss we expected is a 500 ml, which is considered as a normal. More than any 500 ml is considered to be abnormal, that is termed as the PPH. Findings clinical differ with the loss more than 500 to 750 ml, 750 to 1000, and more than 1 liter. The clinical finding differs a lot. And practically, if the loss is 1/3 of the blood volume, that is more than 2000 liter, then the patient is termed as an extremely severe PPH, and that requires the urgent attention and has got a very high morbidity and mortality. Next one, please, sir. Diagnosing is naturally initial evaluation, then the examination of the hemorrhage, and then there's some supported by the laboratory assessments. Next slide, sir, please. Now, this is all methodical tabular format, how to approach with the PPH and target oriented with the what are the finding out the cause. That is, for example, if there is a poor uterine tone, how we should go. If there is a tears and trauma, how we should go. If there is a retained tissue, that is a retained placenta. If there is a placenta abnormality, right, accreta, increta, percreta, and all those things, then how the management differs. Usually, as far as the trauma and the retained tissue and are related, that requires the surgical intervention. As far as the tone is considered, majority times the medical management takes care of the tone factor or atony. If at all it is not getting subsided or treated with the drugs or medical line of management, you may need to have intervention surgically. And for the thrombin, that is for the coagulation factor, there is a different treatment altogether, and that is related to the blood components. Next one, sir, please. Now, there is a rationale for treating the atony of the uterus. As now, during the cases, I will discuss the atony of the uterus. That is the commonest cause in the PPH. The atony may be result of excessive stretching of the uterus. That may be because of the hydramnios, polyhydramnios, multiple pregnancy, multiparity, over-distended uterus, and those factors lead to the fatigue of uterus, fatigue of the uterine muscles, and that leads to the atony. Precipitate labors, prolonged labor, all these factors lead to the fatigue of uterine muscle, and that causes the atony. This is a preventable condition, can be anticipated, like polyhydramnios, multiple pregnancy, you can anticipate this. Prolonged labor, you can anticipate this. You have to be prepared for the atonic PPH. Now, this is a medically treatable condition, but prevention is extremely important. And as we know, as per the FOXI, WHO, or guidelines says there should be active management of third stage of labor. Right now, we were using the routinely format like oxytocin, then prostaglandins, and ergot derivatives. Now there is a fourth one drug which has recently come into the market, and that is a carbetocin. We will go to the next slide, sir. Related with the temperature and all those things we will discuss during the drugs manufacture. These are the all molecules which are used for the as a uterotonic agent: oxytocin, carbetocin, ergometrin or ergoterothin. There is a symptometrin, iron or symptometrin available in our city. That is a combination of oxytocin with the ergometrin. And there is a misoprostol. Misoprostol advantage is easily administrable. That is a rectal use. Any staff can use this drug. That is the biggest advantage of misoprostol. Next one, sir. Now, carbetocin. Yeah, we will go to the clinical evidence. Now, there was a huge trial carried out on the carbetocin. It was labeled champion trials. Everyone knows champion trials is an extremely famous trial carried out on more than 30,000 patients across the world, including in India. And that trial study are very assuring for the carbetocin drug for the prevention of PPH. And this study was carried out to differentiate between the uses of the carbetocin and effectiveness of the carbetocin as against the oxytocin drugs with respect to the amount of blood loss. The proportion of the blood loss that is found after the use of carbetocin was much more similar or effective as far as the oxytocin is considered, with some added advantage of the drugs or the molecule. Next one, sir. Now, this is the tabular information about the differences about this champion study. And as you can see, the blood loss of more than 500 ml efficacy as far as the oxytocin and carbetocin, we find that it's not at all inferior. It's equal to the oxytocin. Blood loss in respect to the 500 ml, blood loss as respect to the 1 liter, and the safety profile of the carbetocin as compared to the oxytocin appears to be absolutely in equal terms and condition in equal percentage. In no way the carbetocin seems to be inferior to the oxytocin in respect to the blood loss or the side effects. That is the major outcome or finding of this champion trial carried out worldwide. Next one, sir. This was the Cochrane review. The importance of the Cochrane and champion review, there's a huge number of patients because allopathy believes in huge number of patients. We don't believe in 100 patient trial, 200 patient trial, or 1000 patient trial. We require to have a sizable data, and then only we can draw some conclusion or inferences. The Cochrane review always the author conclude that for women who undergo cesarean section or carbetocin resulted in a satisfactory significant reduction in the need of therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with the less blood loss compared to symptometry in the prevention of PPH for the woman who has vaginal deliveries and is associated with significantly fewer adverse effects. That is the main concrete findings about the Cochrane review. Next slide, sir, please. There are the now these worldwide the benefits of carbetocin has been proved beyond doubt in preventing the uterine atony. Now, WHO and various trials in the Canada, in the New Zealand by FIGO, everybody was of the opinion that carbetocin can be recommended as an active management of third stage of labor or for the PPH management. That is the basic output of these various guidelines which have come out from the various studies carried out worldwide, including the FIGO. Next one, sir. Now, as every doctor or obstetrician is concerned, whenever the new drugs comes, whenever any new drugs comes, every obstetrician or doctor is concerned whether to use these drugs or not, or whether to wait for the other doctors to have their own experiences. And this concern is basically because of the side effects of the drugs. Whenever any new molecule comes, every doctor is concerned about the side effects. And whenever any IV drugs comes, we are concerned more about the anaphylactic reactions because we can't afford any maternal mortality in our hospital because that has got an extremely huge significance, social impact, and government inquiries. So whenever the carbetocin drug was newly introduced, particularly myself, I prefer to have a wait and watch patients' technology. This is the policy. Let the other doctors use, let they come out with their expenses and uses. Then I will think about it. I think my hospital has designed the same policy for all drugs, not only for carbetocin. But carbetocin, I was a little bit more safer because carbetocin drugs is coming from the oxytocin family. And we are using the oxytocin drugs since our ages. Now, I got a 35 years of private practice, plus some 8 years of studies. So practically, we are familiar with the oxytocin drugs right from the more than 40 years. And whenever any drug is belonging to a particular reputed family, then naturally we feel a little bit more confident about that drug rather than absolutely any new molecule coming out. So carbetocin, we had little hiccups initially, but we still, as a policy, our hospital policy, we waited for the drug for the other doctors to use. And then after this drug has come into the practice for more than 1 year, I initially started using the carbetocin drugs in selectively in all cesarean section cases. The reason for using this drug during the cesarean section was availability of the assistant doctors, availability of the anesthetist standby. So if at all something goes wrong, then naturally there is more manpower, more doctors, and especially anesthetists will be there to tackle the side effects if at all it happens. So slowly we started using the carbetocin drugs for all our cesarean section cases, including normal cesarean section, including multiple pregnancy, including then the hypertension disorders with the pregnancy. I have not used it only during the cardiac diseases or pulmonary diseases, especially those patients are having pneumonia and severe bronchial asthma. I have not used these up in those selected cases. And I noticed whenever we were using the carbetocin during the cesarean section, as we take out the baby and settle out the angles of the uterus, take out the lower segment of the uterus, see for the bladder bleeding, till that time, usually placenta used to get out expelled spontaneously within the giving the dose of carbetocin. So we never had to separate the placenta manually during the use of carbetocin, or never has to give any traction to the placenta for its separation. That was our finding. Till the carbetocin drug was getting over, usually placenta used to get separate automatically. That boosted our confidence, and then we started using the carbetocin practically for all normal delivery patients, whether it is a primary, whether it is a vaginal birth of the cesarean section, or whether it is for any other patient except cardiac disease patients. And our experience for this drug was the blood loss was extremely manageable condition. We never had any PPH except certain conditions where we had to use another dose of uterotonics in certain patients. That means the percentage may be around 3 to 5% of patients where we needed to give second dose of uterotonics because the efficacy or effectiveness of these drugs that was not sufficient to our expectation, and especially whenever there is a patient of placenta previa or initially a placenta accreta, where we haven't to proceed for any other surgical interventions, we needed a drug which will contract the lower segment also absolutely properly. Our observation was carbetocin drugs do act effectively in the upper segment portion, but in the lower segment portion, the effectiveness is a little bit less. The reason being that polarity, it maintains the polarity of contraction. Being a drug from the oxytocin group of family, oxytocin maintains the polarity of contractions of the uterine muscles. Polarity means whenever upper uterine segment contracts, the lower segment is expected to dilate. And that is why the oxytocin is used for the induction of labor. The dilatation should be there, the lower segment. Naturally, this becomes the adverse for whenever there is a bleeding from the lower segment. And there we need addition of another drugs to have a tetanic contraction of the lower segment. I have used these drugs particularly now since practically I think it's 2 years. I'm exclusively using this drug for the AMTs, and that is active management of third stage of labor. And my personal experience is absolutely happy. For example, consider 30 delivery per month. So practically 350 around per year, around 700 deliveries. So my experience with this carbetocin is very good, very safe, and I haven't come across with any adverse effect with the carbetocin. I have not used this drug only in certain patients. For example, my hospital is not recognized for it. I am not conducting the second stage or second trimester abortions in my hospital because I am not doing the MTP. That is somehow our policy in hospital. Since last 3 years, we are not doing the MTPs. So I am not aware of this uses of this drug in the second trimester abortion. I have not used this drug during the vesicular mole because this is a new, I don't know, because we are not using any drugs which will cause the severe contraction of the upper segment for the fear of embolization of the vesicles into the intravascular segment. So I have got a limited experience, or practically no experience of this drug with the second trimester abortion and with the vesicular bone drugs. We can go to the next slide. If there is a panel discussion, we can go straight away. Yeah. Certain things about the carbetocins where I will like to avoid these drugs, practically in the sepsis. Whenever there is a patient of chorioamnionitis, and we think that there is an amount of sepsis will be there, septicemia is likely to happen to the patient. So we are using this drug, natural oxytocin, we are preferring more because here again we don't want to spread the infection into the systematic. As the availability of data is not there, so I will prefer oxytocin in this patient who has already got some infection or who is going to land up in the sepsis. The concern about the drugs, from my point of view, I will have to take the time of drug and the timing of administration. That is given is the IV or IM can be given, but we are using as IV. That is a 1 minute, 100 microgram in 1 minute. That timing is a little bit very judicious because if at all the surgeon conducts the delivery, he is bound to conduct the delivery. During the cesarean, he is busy in the surgery. During Caesar, anesthetist give the drugs. He may give us a bolus fast dose. The policy we have adapted to on the safety side is dilute in the 100 ml NS and give it fast. But that drug doesn't get over in 1 minute. That is so minimal drug concentration required probably. That may not be we are getting, but still we are happy with this drug as far as our studies. That concern is there whether it really should be given 1 minute, and if at all, whatever policy we are following, giving the drug in 100 ml saline, even if we go at a fastest speed, that still it requires 2 to 2.5 minutes for you to finish the 100 ml saline. But we are happy with this policy because if at all in some adverse effect happen, I think we can stop the drug. So further dosage becomes the no more. Then secondly, the policy we have adopted is that if at all we are not happy with the first dose, we will never give the second dose as a, like if we are not happy with the oxytocin, we can still add the oxytocin in the 500 ml, continue with the drug with the add-on some other derivatives. But since it's a long half-life of these drugs, second dose is not recommended. Yeah, we are not using the second because 40 to 45 minutes is the half-life of drug. If the drug action is, we are not happy, we can't wait for 40 minutes, we have to give the other drug immediately. Then we will like to give a more uterotonic drug, and that will be ergot or prostaglandin drug. Then thirdly, up till now, we have not used this drug in the cardiac patients and with the pulmonary causes, with the fear that oxytocin has got some reservation about uses of oxytocin in the cardiac patient because of some whether the issue is related with the drugs or fluid overload. That is a debatable topic. Yeah. But some obstetricians are using oxytocin as an IV bolus, which is not a recommended. But I have seen some anesthetists and some obstetricians, they are using this as a bolus dose during as an AMTSL, active management of the testosal labor. Recommended dose is always IM, 10 units IM at the anterior shoulder. So I don't know whether this cardiac element can be attributed to the oxytocin molecule or it's a fluid overload. But the cardiologists, usually they are unhappy with the ergometry, they are unhappy with the oxytocin. So we are resorting to the naturally 10 units intramuscular oxytocin followed by the misoprostol, if at all required rectally, as a safer
alternative.
Yeah. So that's all about my understanding of this drug and my uses of these drugs.
Wonderful, sir. Your insights are more important than the theoretical aspects. And I'm sure these insights will help the doctors who are attending. Some of the questions from the panel. We have already answered your experience about Carbetocin. Which patient profile can you anticipate PPH?
Wherever there is a muscle fatigue is bound to happen. It may be because of the over distension, it may be because of the prolonged labor, and it may be because of the some tissue remaining like placental.
Placenta.
These patients are highly prone for the PPH.
Patients with diabetes, are they more prone for PPH or
Because of the
hypertension?
over distension, because of the
Over this.
macrosomic babies.
Okay. And twins, of course, will be because of the over distension. Twins also will be patients with twins. When would you actually prefer a carbetocin over oxytocin for prevention of PPH?
Now, to be frank, we are using as the first line of drug because if at all, our in a private practice, we give a preference of more to prevention rather than the cost factor.
Exactly.
In a private practice, it's a cost is not immaterial. We want to have safety as a more important factor. So naturally, we are using this first 2 years as a first line of drugs. So there is no
Question.
basic limitation of this drug is cannot be used as an induction of labor. That is the
Yeah, that
absolute
is correct. There's
limitation of
only oxytocin
there.
can be used.
Oxygen has got its own role.
Yeah,
So
yeah.
the oxygen will remain bound to be there. So
It's a
oxygen,
textbook brand, sir. It will always remain.
yeah, it will always remain for
Yeah.
induction.
Can we use carbetocin? Now, these questions have come across India. Can we use carbetocin in case of retained placenta? Your opinion, you may not have used or I do not know.
Now, this can be used as the first line of drug like oxytocin or
Oxytocin.
yeah. But for such retained placenta patients, after removal of a placenta, we may
Yeah,
need
yeah.
other drugs. And the only limitation of this carbetocin is that after giving the carbetocin, we cannot continue the oxytocin drug because
Yeah,
the same
absolutely.
being occupied.
Receptor,
We
correct.
have to add some another drugs like ergoterone or prostaglandin.
Correct. Same is the case with Rh negative mothers.
Yeah, there is a oxytocin family group, so I don't think
And
there
Rh
is.
negative, there's a PPH, it's a big trouble because you should get that blood and I mean,
Yeah,
especially the interiors, it may not be practical always.
correct.
If a doctor uses carbetocin for prevention, can a doctor use carbetocin for prevention if oxytocin used for induction?
Yeah, before oxytocin is being used, then the carbetocin has got role prior to oxytocin, but carbetocin has got no role after any oxytocin has got no role after the carbetocin.
After
And vice
carbetocin.
versa is true.
Yeah, the reverse is
It
not
can
true.
be used after oxytocin,
But oxytocin cannot be used after
but
carbetocin
oxytocin cannot be used after carbetocin
because of the receptor blockade.
because of the receptor blockade.
In which cases would you prefer IV over IM? I mean, this specific because IM also will have a role somewhere if because the duration of action will be longer.
But naturally, our policies we do put an intracath in all patients.
Okay. So
So
IV is
that
no issue. IV is no issue.
we don't know. So naturally, it's always safer to give the IV
Correct.
because turning on the patient and giving some other sides, all our areas, thighs are usually spoiled, buttocks are spoiled. That takes some time.
Correct. Correct.
Get your anterior shoulder, give the IV position. Where you get the time, you are taking out the baby, you are
Yeah,
cramping.
yeah, yeah, yeah.
You will give
Practically, it's difficult to give IM.
practically
Completely
difficult.
agree. Yeah,
And
yeah.
usually we don't prefer giving injection on the arms because hands are extremely important organs.
Absolutely. Yeah.
Always give over the buttocks
Yeah.
or thighs. But this
That time is
practically
not
is not
possible.
possible. Push the
Correct. Correct.
carbon over there. We usually keep the carbon prepared 100 ml in there. I don't know whether it is authorized, but we are using since 2 years. We are happy with this policy.
Correct. IV.
Yeah, IV policy in a 100 ml solution.
Yes. If the patient, suppose, does not respond adequately with carbetocin, what additional uretonics you would use?
Now, Argot is a wonderful drug, no doubt.
Okay.
It has got its some side effects naturally, especially
Obviously, every drug will have some.
cardiac and BP. So, if these factors are not there, then Argot is a safer drug.
And we have
If
used ergot since our, I mean, college days.
yeah,
Yeah.
yeah. And basically advantage is lower segment contraction.
Okay.
Ergot steroids has got no polarity,
Okay.
like the oxytocin.
But then how soon the blood pressure shoots with ergot?
Within 5 to 10 minutes.
Oh,
Yeah.
very fast.
If you give an IV.
Huh.
Not for all patients, but for hypertension.
Understand. Yeah. But prostaglandins, they themselves they'll have their issues.
They have its own role, so this drug will not get outdated.
Yeah.
Prostaglandin has got its own role, except for the bronchial asthma.
Yeah. And finally, at the end of the day, if a PPH occurs, we will use all drugs available with us. I mean, we will not leave it for
All
one
the
drug.
basket of drugs can be used, should be used.
Yes. Any specific advantage of carbetocin over oxytocin or misoprostol, carboprost, or methyl ergometrin?
Its basic adverse effects are practically very negligible. I haven't encountered any adverse effect up
Single
till
dose could be a major advantage, basically.
time duration.
Duration, yeah.
45 minutes practically, then after 45 minutes, we don't encounter any patient going to the PPH.
Correct. And sir, not requiring a cold chain could also be an advantage, especially
It's
in the
stable, it's an added advantage over the oxytocin.
And
Misoprostol has got its own role in the PSCs in peripheral centers.
Absolutely. And where we do not have so many facilities for IV drip, etc.
Are there easily to insert? Any sister IS can insert these drugs, easily available. So certain drugs have its own role over there.
Unlike prostaglandin, safer in asthmatics also.
Yeah, safer in asthmatic also.
Should it be kept as a reserve drug, or I mean, this question is redundant now after it has come. People use it as first line. Yes.
As a first line only.
And adverse effects about carbetocin, especially I'm talking about the adverse effect of fluid retention.
Oxytocin, that is the disadvantage of oxytocin we require because its half-life is very short. We have very few minutes. So in the maintenance dose, we have to be oxytocin. In the 500 ml salines, you are adding 10 units, 20 units, fluid retention, ADH action over the higher doses. And then these possibilities of pulmonary edema, especially in hypertensive patients, compromised patients, these are extremely high with the oxytocin.
And any adverse side effects you have experienced with carbetocin?
Up till now, rightly, not at all.
And you have been using carbetocin for past 2-3 years?
Over 2 years.
Wonderful. And one line, your conclusion on carbetocin.
From my point of view, our limited 2-year sequence is equally effective, equally safe. There is a tolerability. We haven't observed any patient doing vomiting, doing something like coronary spasm after the ergometry. Patient do complaints of chest pain because the coronary spasm do occur. And if certain patients have got a myocardial breach, which is a rare abnormality of coronary vessels, which is never diagnosed, cannot be diagnosed because these patients are absolutely asymptomatic. This carbetocin, we have find any this reason like fever, chills, which is with the misoprostols, no vomiting sensation, no cardiac compression or chest pain, no vomiting. It's quite safe. And I don't know if after giving carbetocin, immediately uterus relaxes. That is efficacy may be lower in certain patients, probably. I don't know the reason. That may be related with the time. But then with the second line of drug, usually we never required any surgical intervention up till now. It's we are using this drug as a first line of treatment. Equally.
Anytime you have requests to add something after carbetocin use, or it's quite, it has worked by itself.
Yeah.
Anyway, thank you so much, doctor, for your insights. It was lovely practical insights. I'm sure it has helped the audience. Thank you so much for your time. Thanks all the participating doctors. I'm sure you must have benefited from Dr. Abhay's inputs. Thank you for taking time and attending this webinar. Thank you, marketing team Hitro, for conceptualizing this, and thank you, field people, for coordination. And last but not the least, thank you, IT team Jayant, for your IT help. Thanks all of you, and signing off. Thank you. Thanks, sir. Thanks, Jayant.
Yes, thank you.
Yes, sir, I can leave, Jayant?
Yes, you can leave.
Thanks, Jayant.
Yeah, thank you.